You are listening to Concussion 101, a patient's guide to getting ahead again. Episode 6, Down But Not Out. Today your host, Dr. Taher Chugh, Sports MD and Medical Director at York Region Concussion Clinic, is back in this episode to demystify and destigmatize common mood and behavioral changes post-concussion. Enjoy.
Welcome to another podcast in this series. So it's me again, Caitlin Hano, the occupational therapist from our clinic. I will be interviewing Dr. Chugh to discuss some of the psychological issues that can result from concussions. So let's get started. What kind of psychological conditions do you see in the context of concussion?
We see a lot of personality or surface level changes. There are a few stereotypical responses we see most commonly.
Okay, let's start with children and adolescents.
Adolescents tend to look more flat. They don't smile as much and they speak very little. When we ask them what they do all day, they just say nothing. Or they say they walk around the house or just lay in bed or watch TV.
Their parents must often worry that they're depressed.
Often the kids get frustrated because they're not cleared for sport yet, or they're not doing the things they love to do. The things like video games, social media, things that have been restricted or are uncomfortable for them. Some feel embarrassed because they receive a lot of unwanted attention at school with their accommodations. Some are hard on themselves because they think they deserve it for their negligence in getting the concussion. And some get irritable in the face of the symptoms because they feel the world is going on without them and leaving them behind.
Yeah, I mean, you never know if that's just the patient's baseline personality.
Well, on the one hand, you hear from the parents that Jimmy is the most charming, witty kid. And on the other hand, you know not every kid is charming and witty. But very often, after you see the patients improve a bit, you will start to see what the parents are talking about. The kids start to smile, they make some jokes, they seem more alive and more confident. They especially get happier once we get them back to sports and socializing the way they used to.
Okay, so we covered adolescents. What about adults or middle-aged patients?
They tend to present more with an air of despair. They tend to look more worried, frustrated, and they harbor a sense of being victimized. They tend to want to understand what's happening to them specifically. A common problem is to get them to focus on what they can do and what we're going to do about the problem and how much they've improved rather than how this injury took so much away from them, how the insurance companies and the lawyers not helping them, how their spouses and coworkers don't understand or are not being fair. Things that are beyond their control.
Those all seem to be fair concerns.
Yes, in all fairness, they tend to have more things on their plates. They may be looking after their kids, parents, have uncompromising financial, career, or social commitments, and they're just trying to look after their health in the little time that they have. Many have the attitude that they will just work harder to get it all done and that concessions aren't possible.
I spend a lot of time explaining to people that while our culture generally encourages us to push through the pain, this doesn't apply well to concussion recovery.
Right. This attitude often leads to bad headaches, insomnia, difficulty with reading, problems with cognition, and ultimately not being able to achieve their goals, and thus frustration sets in. Usually there's an ongoing effort by our team to keep them to a rehab schedule, pace their activities, and get them to be kind to themselves, to give themselves a break by accepting the fact of the injury and the potential for recovery.
So when do these problems become actual psychological disorders?
Let me give you a bit of very general background regarding the nature of psychological illness. It hinges largely on the DSM, although in practice, the way healthcare providers use the DSM in diagnosis and treatment is more complicated and beyond the scope of this talk. But as a very simplified introduction, the DSM stands for the Diagnostic and Statistical Manual of Mental Disorders. It is in its 5th edition right now and is put out by the American Psychological Association. It is the compendium used in North America for psychological disorders. It evolved from statistical methods used in acquiring data for psychological problems.
And it's constantly evolving.
All the psychiatric diagnoses are in there. Sometimes new ones are added, and sometimes some are removed and modified. Generally, each diagnosis in there follows the following structure. 1, there's a list of all the criteria that must be met to qualify for that specific diagnosis. The criteria is usually things like signs and symptoms that need to be there for a certain length of time at a certain frequency. 2, one criteria that states that the condition must cause significant impairment in social, occupational, or other important areas of functioning. And 3, that the condition is not due to another general medical condition or substance use. And 4, that the condition is not better explained by another diagnosis in the DSM.
Can you give us an example?
For example, depression is said to occur if for 2 weeks, nearly every day for most of the day, patients experience 5 of the following features, with at least one of the 5 being a depressed mood or loss of interest in things that used to bring them pleasure. So possibilities for the remaining features would be things like sleeping too much or too little, significant weight loss or weight gain, and this is 5% or more, or increased or decreased appetite, that other people see you more physically agitated or you're moving kind of slow, lots of fatigue, feelings of guilt for whatever reason, difficulty concentrating, or recurrent thoughts of death, and this does not refer to a fear of just dying.
That's interesting. So the thing is that we often see these symptoms, these features in our patients. Many on that list are pretty common symptoms post-concussion.
Now, are all of them clinically depressed? We have to ask ourselves how this label will help us. Does it give us any information about what's happening to them psychologically? You see, some of the critics of the DSM say that the diagnosis is too subjective and that depending on the day, you might get a different diagnosis. Some say that it relies too much on subjective symptoms, that the limits on what is normal versus abnormal are kind of arbitrary and may not be true. They say that the DSM presents a bias to medicalize psychological issues.
Right, but we need some guidelines, some common terminology for diagnosis, treatment, and research. Okay, here's a question for you. Is there a post-concussion syndrome in the DSM?
In the DSM-5, there is a mild and major neurocognitive disorder where many post-concussion patients will usually fall. The main features of this are A, cognitive impairment in one or more domains using both subjective and objective reports. B, whether there is departure from baseline functioning. And C, that it's not caused by delirium. Delirium is a condition that's generally not present in the concussion population, so I won't get into it here. But generally, if anyone has ever heard of people going to the hospital with serious medical conditions that resulted, amongst other things, reports of Alice in Wonderland type experiences, that is delirium. It is an acute change in mental function as a result of a general medical condition.
Right.
And then D, we have to exclude competing mental disorders that can better account for the findings.
Right. Okay. So it still looks like there can be a lot of overlap in post-concussion syndrome amongst DSM diagnoses, like that neurocognitive disorder and also depression.
I know it's a long-winded way of getting to your first question. Just to remind the listeners, it was, when do personality changes become actual psychological disorders? But basically, ultimately what matters is the result. Any efficient and safe strategy used to get the patient better is welcome. The diagnosis is just a combination of signs and symptoms that is prevalent in the patient's lives most of the time and that adversely affect their lifestyles.
So your focus is more to look at the signs and symptoms first, and then to look for the potential causes of the same.
Yes. The better you are at doing this, the better treatment you will identify. In the concussion population, other general medical conditions that can have overlapping signs and symptoms are often present and need to be identified and treated. They can be pre-existing or coincidental things like iron deficiency anemia, thyroid issues, or they may have resulted from the concussion, things like issues with patients' visual or vestibular systems, their necks, or autonomic dysfunction issues.
Okay. Makes sense. I mean, the physical symptoms that post-concussion patients face can make them seem depressed. For example, patients with insomnia may feel and look pretty down.
Insomnia is one of the possible features of major depressive disorder. It can also be a specifier for neurocognitive disorder. If, say, for example, a circadian rhythm disorder was the only reason leading to a low mood, fatigue, decreased cognitive abilities, difficulty concentrating, and so on, then it may look like a mood disorder, but technically it wouldn't be. Identifying a circadian rhythm disorder as the cause for insomnia would lead us to a more effective treatment strategy.
It sounds like what you're saying is that we need to identify all possible explanations for the patient's symptoms before we chalk up those symptoms to a purely psychological diagnosis.
Yes. Although, I'm also saying that if the patients appear depressed, we can support their depression. If they appear to have cognitive issues, we can support that. If they appear to be suffering from PTSD-like symptoms, we can help them with that. It's like attacking the problem from both ends, the cause and the effect.
All right. I've heard you refer to concussion management as a clinical Rubik's Cube before. What are some other diagnostic considerations that you have to make before effectively identifying and treating the psychological component of the injury?
This basically goes back to the last podcast where you discussed the biopsychosocial and environmental model of health. Anything we can identify as an issue in physical or lifestyle or environmental and psychological aspects of the patient's lives is fair game. So I already mentioned some of the physical things, but I'll go one step further. In post-concussion patients, many of the deficits we see are interdependent on other things that also may be deficient. How to strategically unravel this chicken and egg relationship between different domains like visual, vestibular, autonomic, hormonal, neck and other musculoskeletal issues, sleep, cognitive and fatigue issues, and so on, is the first clinical Rubik's Cube. Like we mentioned in the first episode, these symptoms can affect one's mood. It also affects patients' ability to function at the level they would like to, which can also affect their mood.
Okay. What are some of the common things that we see in concussion patients in the context of this broader biopsychosocial model?
So 1, lifestyles. This is a broad topic, but most commonly in our patients, lifestyle issues like the ones you mentioned in episode 3 and 4 are prevalent. Not managing their energy well, not picking ideal rest strategies, not having healthy sleep or dietary habits. 2, their psychosocial environment. Most commonly in our clinic, it tends to be family illness or financial stressors that challenge this area. And 3, their psychological makeup. Many of us have pre-injury psychological strengths and weaknesses. We spoke about this during the last episode. And then we have to consider the injury itself and the way it changes the brain function. And finally, in the face of all these things I mentioned, your psychological tenacity is further challenged. This interplay of lifestyle, biology, psychosocial environment, and psychology is the second Rubik's Cube that needs to be solved.
What are some of the common DSM diagnoses that you see post-concussion?
In light of everything I just said, we still use diagnosis because it does give a good idea of the overall impression, and it is a standard of care. Neurocognitive disorders, depression, anxiety disorders, panic attacks, PTSD are the most common ones we see.
Okay. So I know a lot of the time we get a good understanding when we talk about case examples. So could you give us some examples of patients that have had some of these psychological conditions and their stories?
An interesting one is one of a patient we saw recently with panic attacks.
Mm-hmm.
So he was a young man who had developed panic attacks ever since his concussion. They seemed to occur for no rhyme or reason. He would be on the golf course and then suddenly he would be on the 8th hole and get a panic attack that made him retreat to the clubhouse, and he'd have to wait it out so he could drive home. Interestingly, this seemed to be related to breathing abnormalities like you mentioned in the last episode, Caitlin.
Mm-hmm.
This example was on a hot day, so perhaps he was breathing differently or over-breathing less, and this changed his arterial CO2 levels. It is felt that in some chronic overbreathers, there is a sensitivity to slight increases in arterial CO2, and this can cause panic symptoms for no obvious reason. At any rate, he improved with biofeedback guided breathing training in addition to other various therapies he received.
Okay, that was a good one. What about a PTSD example?
We've seen quite a few PTSD patients, mostly from car accidents.
Right.
All received multimodal therapy highlighted in this podcast series, things like cognitive behavioral therapy for insomnia, and just cognitive behavioral therapy in general, energy management, exercise prescription, accommodations, biofeedback, and so on. Some would do well with medications and some wouldn't. One did well with cannabis, which is interesting because there's not much research of its use in this context, but from the limited research out there, this wouldn't be supported yet. But one patient says he feels better than he's felt in 4 years, and sure enough, he started to progress faster in rehabilitation.
Interesting. So addressing the psychological aspect of his injury also helped treat the physical aspect of his illness.
It's the chicken and the egg or the Rubik's Cube analogy again. For some, mood issues hinder any sort of progress, and these need to be addressed up front to facilitate rehabilitation. Whereas in younger patients, it tends to be the other way around. Improving their physical symptoms first will tend to improve their mood. But these are just generalizations.
Can you give us an example of a patient that we saw with PTSD and how they were managed without medication?
So one gentleman's story that I briefly mentioned in episode 1 comes to mind. He benefited from psychotherapy and relaxation. Just to remind you, he was involved in a hit and run, which he caught on his webcam. He actually let me watch it, and I could see his fight or flight system kick in as he covered his eyes while I watched it. What he captured was kind of surreal. The car that hit him was a stolen car, and when the assailant initially got out of the car, the assailant coincidentally was greeted by one of his friends. And then that friend told him to get out of there quickly. The police came and said they couldn't do anything for him because the assailant's friend didn't know anything. So our patient became very anxious around anyone whose appearance tallied with his assailants. He got very nervous around cars. He had a lot of nightmares. His strategy was to bury it deep down and ignore it, but obviously it would keep resurfacing. We had to educate him on the science of conditioned fear and that he couldn't run away from the fear.
Can you summarize what the treatment was for him?
So in addition to the many treatments I already mentioned, like cardiovascular exercise, energy, and sleep management, some specific PTSD strategies he received were 1. Cognitive behavioral therapy. So this addressed many of the maladaptive beliefs, challenged and corrected them. Beliefs he developed about the policing system, for example, the effect of the accident on his life, the culture of his assailant, and so on. 2. Exposure therapy. So he started by watching YouTube videos of people that resembled the assailant, and then progressed to going to malls and exposing himself with the help of his wife. It's kind of funny, but he would describe how he would sidle up close to the person, and then that person would look at him kind of like he was strange, and he would just wave and sheepishly smile and then scurry back to his wife. But it helped. It helped him a lot. 3, he scripted the story by changing the context of the story and making it less threatening. He did the same thing with his dreams. The way he rescripted it was kind of interesting, and he employed some of the beliefs from his culture, and it was effective for him. 4, he employed mindfulness meditation. He tried to do his traditional cultural guided meditation, the one that he used to do before his accident, but he found he couldn't do it anymore because of his PTSD symptoms. So he was turned on to mindfulness meditation, which biofeedback technology showed to have a soothing effect on him. He just would sit there and watch his mind race without following it, as if it were a little child at the park. He knew that the child would eventually tire and come back, and like that, his mind would find calm. The other thing he used was biofeedback. So biofeedback therapy to restore balance of his autonomic nervous system. More specifically, in his case, it blunted his fight or flight system's response to perceived threats.
With psychiatric illness, one does always think of suicide. Can you talk about this?
This is a big topic in and of itself. Suffice it to say that whenever someone has psychological problems, you always have to ask about suicide. And this doesn't increase the risk that the patient will actually go through with suicide. The past medical history becomes important here. As mentioned in previous episodes, in concussion, you're not just dealing with the effects of the concussion, but also all the pre-existing history and family history. So, for example, we have a young man whose father killed himself within the last year. So this is a large risk factor that needs to be acknowledged, and we need to keep following him closely.
Well, there have been some cases in the media lately.
Most of the cases in the media revolve around chronic traumatic encephalopathy, or from people with numerous concussions and extensive neuropsychological changes. It does happen, but not commonly.
Okay, well, let's get really general. How do we treat psychological issues post-concussion?
1, educating the patient demystifies it. It helps remove the fear. Fear stimulates the sympathetic nervous system, which you discussed in the last episode. 2, educating the family. It helps foster understanding in a supportive environment. Often post-concussion patients have good days and not so good days. Sometimes families see this as a patient being difficult. However, when they're given a scientific explanation for this, for example, how autonomic dysfunction will worsen with fatigue or a poor night's sleep and will then affect the patient's mood and concentration, and say, for example, her binocular vision issues, which can in turn cause headaches, the family becomes more tolerant and it takes some pressure off from the patient.
Okay. Knowledge is power. What else?
Exercise reintroduction.
Yes, exercise is so important to so many people and can have similar effect sizes in treating mood disorders to medication and psychotherapy. All right, what else can we do?
4, identifying and treating physical symptoms. These are big topics, and we'll continue to touch upon this in this podcast series. Another thing would be optimizing the treatment of other pre-existing or overlapping general medical conditions. This is where we often work to coordinate care with our family doctors. Sixth thing would be psychological techniques like CBT, mindfulness, relaxation therapy. 7 would be lifestyle issues like energy management, sleep management, and dietary management.
And this includes giving them appropriate accommodations so that, their days are not so taxing and that they're not too spent to do their therapy exercises.
Yeah, often this involves a modified work schedule or an absence from work for a while. Supporting patients with securing the funding they need from their insurance company so that they can have the time to properly recover is key.
Okay. You mentioned that biofeedback was used in a few of the examples that you gave in this episode. Can you tell me more?
This is an effective modality to teach them to regulate their autonomic nervous system's response to stress-induced triggers. The autonomic nervous system's response can appear clinically as both physical or psychological symptoms.
I noticed you haven't mentioned medication yet.
Medications for some. There are a few in the program who have needed it. Unless there is a pressing indication, we usually reserve this for the last, as we have to consider the side effects that it might exploit some other medical problems. For example, many medications may adversely affect visual accommodation, which can worsen headaches and light sensitivity, or some may make cognitive issues worse. On the flip side, some medication helps with chronic back and neck pain.
I have seen some patients do well with psychotherapy, and others haven't had the best outcome. Can you comment on this?
Well, given what we just discussed, it's clear that no one factor is sufficient in and of itself. Usually you need to approach the issue on many different fronts. So perhaps those that didn't have the best outcome didn't have multimodal care to the same extent as those that did have good outcomes.
I also feel strongly that, based on research and current treatment guidelines for depression, for example, there is a role for psychotherapy, medication, and exercise, but every person is unique, and some techniques may work better for some people than others.
For the treating team, finding the right balance between flexibility and structure is usually rewarded.
When is it time to involve a psychologist?
I think everyone can benefit from a psychologist. That's not to say everyone has psychological problems. I just mean to say that if we can improve our psychological performance, it will help. In our program, we spend time with patients employing several psychological techniques like CBT, mindfulness, relaxation training, and so on. Practically speaking, however, the patients who tend to end up seeing psychologists are the patients that have the worst psychological consequences or have pre-existing psychological concerns.
And psychotherapy itself, that's an incredibly broad category of treatment.
Yeah, most psychologists identify themselves as eclectic therapists, and they draw on many techniques from a variety of different types of therapy, things like dynamic, cognitive, and behavioral approaches. So one skill set may or may not match up efficiently with the patient's psychological makeup or cultural beliefs or medical conditions. Finally, like for any medical professional, rapport becomes important, especially with sensitive matters like psychological ones.
I feel, too, that there still seems to be a bit of a stigma surrounding reaching out for psychological support.
I agree. What do you tell these people?
Well, I see it as a therapy like any other, and even those of us who don't struggle with any symptoms of depression or anxiety, who can't benefit from having someone objective, so someone not personally involved in your day-to-day life, to talk to?
I mean, the injury for many has changed their lifestyles and the way they approach common mundane things that they do every day. It has given them many symptoms. It has changed the way their neural circuitry fires. In effect, they are not themselves anymore. Psychological therapy is just about understanding the changes that have occurred and how to set them right. And as I've mentioned, treating the psychological side of the concussion can sometimes be the difference between a quick recovery and a prolonged syndrome.
You can see how it takes a whole team to help.
That's a common theme that keeps resurfacing in this podcast. I couldn't imagine treating patients without a team at the helm.
Well, that brings us to the end of this podcast, talking about mood and some of the psychological issues that occur in concussion. Thank you, Dr. Chugh, for all of that education. Feel free to join us next time where we will be discussing neck pain and dysfunction.
Thank you for listening to the Concussion 101 podcast. If you enjoyed it, please subscribe to our podcast on iTunes and leave us a review. For more information about concussion-related topics, visit us at www.yorkconcussion.ca. Stay tuned for our next episode.